First session, we're going to be talking about ankle fractures in the elderly in particular. So I think this is a topic that's a lot of us who take care of trauma are managing on a regular basis. I do have some conflicts there in the program. Want to introduce our panel. Dr. Samir Mehta at Penn had backup for the OR today. Apparently didn't work out. Dr. Mehta, can we just make sure your audio is working? We can hear you.
Can you hear me okay?
I can hear you okay. Can you guys hear him?
Yep.
Yes. Okay, perfect.
Awesome. All right, great. Thank you.
Excellent. Thanks for joining us. We have Gene Shaffer from Einstein, Phil Ryan at Jefferson, and Jim Lachman at St. Luke's. Weird thing is, this is like the same exact panel I did in the first. I didn't realize this when I put this together, but somehow it's the same exact panelists, a completely different session that we did last year. Actually, it wasn't that different. It was not ankles, but it was similar topic.
People don't like foot, Saqib. That's why it's the same guys.
Well, appreciate you guys coming back. So let's get into it. So, like I said, I think these are common injuries, and I think it's interesting, when you think about ankle fractures, a lot of times it doesn't always, for those of us who take care of it, working in a residency program, I mean, sometimes it seems like it's maybe not the most complex case. Maybe in a lot of programs, we even have a junior resident kind of, leading the case, and then you realize that ankle fractures can be really bad. There's all kinds of issues that can create problems. It's the kind of fracture that often gets underestimated because it doesn't seem like a big, pelvic fracture or something like that, and it's an ankle, and they're common. We should be able to manage them, but there's a lot of issues you can run into trouble. So in the elderly, we have issues related to the fact that it's a very common fracture. The incidence is expected to rise. And the other thing is you run into these 4 problems, right? And there's probably more problems, but this is kind of how I break it down. Poor bone quality, right? Something we face with any osteoporotic fracture, but of course you can't ignore that when treating elderly ankle fractures. Increased medical comorbidities. So, these patients obviously have medical problems that can complicate their care and their rehabilitation. Worse soft tissue envelope, and you saw some clinical images I showed previously that reflect that you may have poor skin, that can make wound closure challenging, can make wound infections and healing at more risk for complication. And there's also a need for early mobilization. So if you have a 22-year-old patient with an ankle fracture, maybe they can be on crutches for a prolonged period of time if they need to. An elderly person may not be able to even utilize crutches. It's challenging when you really have to get these people moving. And all these things converge with the management of these. So before we get into the cases, very briefly, I'll just outline some of the slightly different treatment options that we look into when managing elderly ankle fractures. So more fixation, right? I think you always want good fixation, but we tend to go, I would say, a little overboard intentionally when treating an elderly patient that you're worried, for instance, about the need for maybe they're going to walk on it sooner, the need for better fixation because the bone's not good, and you'll see some examples of that. Because of the concerns for wound healing, if you open and plate a lateral malleolus, it's not always benign in a patient with with bad skin or an elderly patient that might not have the best soft tissues. So intramedullary nail fixation of the fibula becomes an option. Even intramedullary nailing of the tibia, essentially, you'll see some cases of that. And I think another thing to think about is, whereas you may usually want to get very early motion, neutralizing, in a brace or a cast even, and there may even be cases for an X fix to provide additional neutralization support of your fixation. All right, so those are some of the, I think, thoughts that we'll be coming back to, and we'll also try to go through some evidence of the things you're going to see. So I'm going to just mention my panelists were very generous and providing some cases that we're going to go through, and maybe I'll ask that the panelists kind of hold off on identifying if that's your case or not until we get into it. And there's going to come a point where we're going to have to ask you. So, but so that way, I guess everybody can feel free to attack whatever's happening. If you think it's terrible, Jim, just, I know you're not going to hold back. So just say what you need to say, and then we can hash it out later at happy hour. All right. So 83-year-old female admitted for right ankle injury sustained during ground level fall, ambulates with a rollator at baseline, sarcomerally tooth disease, and a whole bunch of other problems. On Eliquis, so even better. There's your presenting X-ray. Obviously, a little hard to see what's going on. So here's some post-reduction X-rays, and the patient's splinted. I'm going to come back to some of these images, but since there's a little bit more here, I'm going to show you. There's some scans here that might be helpful for you. Okay, and just to go back, that's kind of what you're looking at. So, 83-year-old female, low energy fall, rollator, Charcot-Marie tooth neuropathy, on Eliquis, lots of medical issues. That's what you're dealing with.
This closed?
Closed.
Okay.
Closed. Let's start with you, Samir. What are your thoughts?
I always think about non-operative, and how much torture that's going to be for myself and for the patient. This is one, I mean, it looks great, reduced, and if she heals like that, she will be fine. The question is can you get her to union with that X-ray, the post-production X-ray, treating her in a cast, non-weight bearing, without causing her some kind of soft tissue issue, given her neuropathy and her likely inability to weight bear. And so if you go forward one click.
I'm not going to show you the what was done.
I'm sorry, then go backwards one click. I just want to go to the reduced, one more click. Backwards. Yep. So I mean you could plate that. So one option we try and do this non-operatively. I don't think she's a great candidate for non-operative, but I would have that conversation with her in the office and see if she can maintain non-weight bearing with a knee scooter or something like that. Sometimes these patients can do that. They've got good support. And if she does, then I would bring her back probably every week and a half or so and change her cast out and give it 6 to 8 weeks and see if I can get her to union. So that would be my desire if I can, without causing some kind of soft tissue complication.
Bill, what do you think of that?
So I was actually just going to follow up with a question to Dr. Mehta. If you're thinking non-surgical as an option, how long are you thinking for a time frame for
yeah, so I would probably think somewhere in that 6 to 8 week range, getting her out of the cast into a boot and have her weight bear. Recognizing that it might take her a little bit longer to heal, but I can't keep her non-weight bearing for like 3 months, like a diabetic ankle or something. And so I'm not saying that that's definitely what I would do, but it would be an option, right? Because once you cut her, you own her. And I can share with you plenty of X-rays where you go back and you're like, why did I even operate on this?
Yeah, I agree. I may treat more of these non-op than most, and I just yell at them not to walk on it. I don't think 6 to 8 weeks of non-weight bearing will be enough to keep it in the right spot. That fibula is really dusted, and it's not like you're going to get no support even if it's a little sticky at 8 weeks, which it probably won't be. She's a neuropathy from not diabetic, more common. We see a lot of diabetic neuropathies, and she's a Charcot. I always check their A1C, no matter that they don't think they're diabetic, to see if that's not involved as well. So it's a little bit different neuropathy maybe. But yeah, I think the point is if you can keep that talus under the tibia any way, that's your goal, and a cast can get you there. But I think I mean, usually it's double the length of non-weight bearing and immobilization. It's tricky though with she's 83, you got to get her out of bed.
Jim,
Yeah,
can
so
we-
Gene, so Gene, you're going to keep her a non-weight bearing on this leg for at least 12 weeks,
10 to 12.
10 to 12. Okay. Yeah, I don't have a problem with that as long as she can maintain it. And I agree. I think 6 to 8 is probably a little short, but I think when you start to get past that 6 to 8 week mark with these elderly, it becomes a challenge for them. And like you said, getting them out of bed and moving.
what do you think, Jim?
Yeah, I don't have much to add except what Samir alluded to is that if you're volunteering for non-surgical treatment here, it's not like the pain is any less, right? That's a very difficult patient in the clinic because they're going to come in a stretcher and you and your assistant are going to have to hold this thing reduced while you change the cast. You're going to have to make sure that you pad the cast so that this, very, very fragile skin patient doesn't end up having wound healing issues. So I don't think that it's not like it's an easy solution, choosing non-surgical treatment. You're still signing up for a long road with this patient. I actually lean more towards in these patients, if I can, bringing them to the operating room because I actually think that that's the path of least pain for both myself, which obviously the selfish reason, but also for the patient.
What would you do?
How I would fix it.
Yeah.
So in a patient with this type of history, I like using the posterolateral approach just because it is a safer approach. A couple of studies have suggested that as far as wound healing goes, your soft tissue envelope is much more forgiving. You can get to that fibula, although that fibula doesn't look like there's going to be anything to lag. You're probably just going to be bridging that. And then as far as the medial malleolus goes, there was what I thought I saw on the axial fatigue was some medial or marginal impaction on the medial side of that medial malleolus fracture, excuse me, the lateral side of that medial malleolus fracture. And so, if you thought you could get it percutaneously, I guess you could do that to try and minimize your wounds on that side. But yeah, I lean more towards fixing these when I can.
Okay.
That being said, I have a resident in the room who we non-opt a patient just like this because she was on 3 liters of oxygen and told me she would die on the operating room table. So we just did that this week. I obviously not an easy situation.
Would you
Well,
fix your mouth?
Yeah, I would. Yeah. I mean, I'm a foot and ankle surgeon, not a trauma guy. So we fix the posterior mal essentially all the time. And that's what that gives me even more reason to do posterolateral is that she's got this relatively unstable and large posterior mal. I like the way she's lined up though. If somebody told me they wanted to cast her, I wouldn't argue with them. I think that's a reasonable option, but just
Let me take a quick vote then. We have a few options here. And you guys can vote as well as show of hands in the room. Cast. My man. Who else? That's it? Like, raise them high so we can see.
Room is
Cast.
silence.
Well, Dr. Mehta's with you. Okay, great. All right. ORAF, just plates and screws of some variety. Bunch
Well,
of
you
hands.
say some variety, but I think it's really important to talk about what variety that is.
Oh,
So we can
we'll
talk.
get,
Okay.
we'll get into that. We'll get into that. Hindfoot nail. Bunch of people say for hindfoot nail. Okay, and there's lots of other permutations, and definitely if you're fixing it, like Dr. Mehta said, there's gonna be a lot of different ways. Dr. Lachman already came up with a couple of options.
Ask how many people have amputated somebody after they tried to fix them RIF. Raise hands.
You just asked the question. Okay. Couple of people have had to amputate. Thoughts, Gene?
Yeah, I mean, the talus is in the right spot. It's a pretty robust plate on the side, the extra screws into the tibia, more bone. The displacement, the fibula, the distal fibula, you've got the locking screws in there, but that's probably what all this rests on, especially if you're going to move her early. And then the posterior mal is lined up pretty well, but not necessarily stabilized. The big long screw in the medial side is great for osteopenic bone. And the skin envelope, we're obviously not seeing here, but that's all of this as well. If you fix it well and it stays in the right spot, but you're looking at the plate in 3 or 4 weeks, then you have a bigger problem.
3 weeks. We're not looking at the plate, but X-rays look like that. Jim, what do you think?
I don't think it looks good.
Okay.
Yeah, I mean, this is a big fear, right? This patient has poor bone and her fixation is failing. I can't say that this would, you really fixed it, whoever did this fixed this really robustly laterally. And so I can't say that that's a problem that I have here, but I always think back to, when this talus starts to escape posterolaterally and there's a posterior malleolus fracture that is there. I'm not so sure that this was the most rigid way to fix something like this.
Bill?
Whether that would have made a difference or not, who knows?
Go back one for a second, Saqib. And forward. The multiple syndesmotic screws do all kinds of crazy things. The bottom two are just pulling back, obviously. I've seen with two syndesmotic screws that Z or scissor effect where one starts to seem like it advances and the other one pulls back. The top screw is in the same spot. It's grabbing medial cortex, what you want to get for maximum fixation. But this shows that the fibula, the comminution, it's a tiny little low piece of bone with terrible bone stock. Doesn't matter how much you fix above it. If it's not going to stay, it's not going to stay.
Can you go back a slide? I don't have a problem with this construct. I actually probably wouldn't even fix the medial side. I tend to use a longer plate on the lateral side. And I tend to go, if they have a posterior malleolus, I tend to put that distal quad cortical screw as close to the joint as I can. And I think if you're going to fix this, I don't have a problem with not fixing the posterior aspect for this scenario for this patient. And I don't have a problem actually even not fixing the medial side, as long as you get your fibular length back, and as long as you get really, really rigid long fixation of the fibula with quad cortical fixation across the tib fib. This is disappointing. There are a few things I would have done differently here, but I don't think I would have done much differently in terms of the overall concept and construct. Again, I probably would have put less fixation on the medial side and more fixation on the lateral side.
Bill, what do you think? I'm going to show you the next X-ray.
Yeah, I mean.
Okay, now we're 6
have the
weeks.
advantage of knowing what's going on.
What's that?
I will tell you, her contralateral limb looked very valgus as well. She had a planovalgus leg. Obviously, you can see the early construct failing, but she was not having pain. I think ultimately that's because she's underestimating the amount initially of how dense her neuropathy was.
Okay, so now what? Jim, what are you thinking? It's 3 months. This is not working. You already told the patient that 6 weeks no good. So
When you say not working, she's having issues walking, she's having pain, she's complaining. There's wounds. I mean, so obviously there's so many different ways that this could be a problem for someone, but I tend to agree with Bill. If it's not a problem, you could certainly watch it. But yeah, here I think in an 80-something-year-old patient, I would go to a TTC fusion at this point. And I prepare the joints in all those, so I would prepare the joints in this lady too.
So let's go through that. Here's now, Bill, is your case.
Yeah.
So maybe you can walk us through here a little bit.
Yeah, and then also back to Jim's point. So initially when I started 6 weeks, I was like, try to protect yourself, stay off it. I think she couldn't self-limit. She was having no pain, but then she had this progressive lateral valgus. And so clearly at the 3-month mark, broken hardware, failing more into valgus. I think at that time it's appropriate for me to pull the trigger. So that I made the same decision. TTC now. So you can see here.
Can I stop you just before we move on? So when you cast a patient, right? And Samir and Gene went over that, like the length of time that you cast them. A lot of times when you cast them and they have this flat foot, they're gonna, even after you take them out of the cast and it looks like on x-ray they've healed, they're gonna slip into that a little bit of valgus, right? And don't think that an 83-year-old in an Arizona brace is really going to complain to you that much if you were able to avoid a surgery, right? And so if I'm going to cast someone, I tell them, we might not be able to get this perfect in a cast, even though this patient looked pretty perfect in a cast. We might not be able to get this perfect in a cast, and even if it heals that way, you may drift a little bit, and you might end up with an ankle arthritis brace at the end of it. I actually have put people in braces with valgus just like this, obviously not with hardware in there, but just something to bring up is that even when you go that non-surgical route, a crooked ankle in these patients a lot of times is not something they complain about if you can get them comfortable in an Arizona brace. Not plan A, obviously.
As long as there's a little bit of
Make the
valgus,
point
I think that valgus component is really key. I think a little bit of valgus is okay, and I think they'll tolerate that more so than a little bit of theirs. And so if they fall into a little bit of valgus, I agree with you. I tell them the same thing. It not be perfect, but we can avoid surgery, and you might it might not work great, but you'll be able to walk on it. Most people are okay with that at this age.
Yeah, I agree with all that. I would say the clinical point of the neuropathy, you can't get any clinical sign of healing from patients with neuropathy. They just don't feel and have pain related to their non-healed fracture that gives you any clinical indication. So you can't trust it at all. And also they can displace late. I mean, it's just the poor healing. It can kind of, bend and keep moving where you got to keep an eye on them for a very long time, 6 months longer.
So Bill, any technical tips?
Yeah, so-
Or lessons learned, I guess, at least on the revision? side of it?
For me, my goal for this revision was to minimize soft tissue injury. So that's why I used a percutaneous technique to assist with the reduction. And I left that lateral plate. So I just removed what I would be in my future nail path. And then in terms of adding fixation, knowing that she has poor bone inability to protect herself, there's a locking, a compression screw within that talus to kind of make that a fixed angle device, or as close as it can be, and then an end cap to that nail, posterior end cap, to make that calcaneus screw also fixed angle, because I've seen those occasionally back out when they're cycled repetitively.
Okay, and we're gonna go through one more case and then have a little bit of conversation about like maybe some techniques regarding nailing, and Jim, you mentioned preparing the joint, for example, but so we'll get into that. Another case, 77-year-old female, type 3 open ankle fracture, dislocation after a motor vehicle crash. So again, pretty ugly looking. Don't know what's going on there. But get the talus sort of under the tibia, and there's also a calcaneus fracture. So, Gene, what are you thinking? It's type 3 open, so you got all that.
And any more clinical features, diabetic, neuropathic?
Maybe.
I mean, at the initial presentation, and you got to
Yeah.
keep this in the right spot. I don't do as many X fixes as somebody else, but I think this is a delta frame for me to hold it, watch her soft tissues, get some clinical indicators after you wash her out.
Pin in the talus or bypass the calc or
I don't mind a pin in the talus ever. I see what you're saying.
calc?
I would probably put a pin in the calc and then also do midfoot and forefoot pins for some extra. Again, the goal, keeping that talus under the tibia. I guess if the wound is in the way, then you got a bigger problem. So if the wounds are in the way where the pins would go, then you'd have to hold her in a splint.
Okay, well, I think, it's open, it's gonna need some type of debridement, and, let's say you do something like this. So it undergoes an IND wound closure, and that's what the wounds are looking like. You can see pins, kind of like you said, maybe some, pins in the foot, pin in the calc, tibia pins, and, that's what the soft tissues are looking like. Dr. Mehta, what are you thinking? Going back to this.
Yeah, I mean, 77 open fracture, bone quality not great, badly comminuted, plus the calcaneus. I'm go back slide to your X-ray slide. I'm thinking probably do a hind foot fusion for this. Yeah, I would not prep the joint. I'm not a joint prepper.
Okay.
Doomsday prepper maybe, but not joint prepper. I think I would just put a keel up this ankle, up the fibula, up the calcaneus, up the talus into the tibia, get her alignment on the sagittal and coronal plane, lock the nail proximal, lock the nail distal, and let her sort of just glom in, and I'm going to give her a peg to walk on.
Okay. Bill, any thoughts?
Yeah, I'm, I would like more information in the form of CT first, but I would lean probably towards TTC. The other question is how much her, Bowler's angles collapsed, and whether, she's got a restoration of her calcaneal pitch too. In addition to, and
So,
I would want to know her activity level.
so she might. Activity is, we're gonna say low, but, that's a great question. So yeah, trying to get some reduction is gonna be very challenging here, especially if you are considering, not necessarily doing a formal ORAF. Jim, thoughts?
I think whoever did this knew exactly what they were doing. So yes,
What is that?
I agree. Yes, I thought that calcaneal pitch was unacceptable. I thought a TTC would be great for her. I don't know how. I guess I didn't send you the CT scan, but her medial malleolus was non-existent. I mean, it was gone, and so I didn't see a way to do anything other than fuse her. She also had a little bit of her plafond involved, and I thought this was a Sanders 3, maybe a Sanders 4 calc. And so I like this technique to get if I'm going to do a primary fusion of a Sanders 4, I use this clamp. It allows me to get the pitch back. You have to make sure that the pin that goes through the tuberosity, though, is perfectly perpendicular to the tuberosity, because if you just make it perpendicular to the foot, you're going to lock it in varus.
Does this thing live in your hospital? Do you have to bring this in?
Uh, I had right when I started, I had the striker team get me these, and so
Okay.
it's in a set that they bring when we do
How
these.
often you use it?
I
Couple
don't know.
times a year?
I would say not even a couple times a year,
Okay.
yeah, maybe once every two.
But you know where it
years,
is, in case.
Yeah.
If it's open, I mean, well,
Right.
you did this when you
It's,
brought it back.
it's like a spine like a Hinterman pin distractor.
Take 6.2s and 4.5s. They're really terrific. And they're those, where you put the pins in, you can change the angle on them.
Yes, and then you can leave it on the medial side, right? If you want to keep it out of the way. If I did everything on the lateral side, I didn't want to go through that. I mean, I washed her out a couple of times, but I didn't want to go through that medial wound. And so we get her calcaneus out to length and then do a TTC nail. But I learned from you trauma guys coming to this symposium every year that, in the distal femur, you love this nail over plate construct. And actually, this is described in the Charcot world for foot and ankle reconstructions. And so you can get these patients walking pretty quickly. I let her walk in 3 weeks after this horrible injury. I do prepare the joints for her. She healed them, thank goodness. But unfortunately, I just had to take all this hardware out last week because her medial wound, she just kept draining from her medial wound. She's 9 or 10 months out from her surgery. And so that open fracture wound, we tried to nurse her along. We tried to nurse her along. And eventually I just had to take everything out. She's got a PICC line in. I mean, luckily on the CT scan, everything is healed. So she didn't need this hardware anymore. But that wound in a 77-year-old really proved to be a major issue. It went all the way around past her Achilles, from anteromedial all the way around to posterolateral.
I've seen a couple of cases here of TTC nailing, which is, you've been talking about this, Dan, for years now. I mean, so this is not like absolutely novel, but I think we are at a point where you're seeing this a little bit more often. The residents are seeing this, and it's kind of gone from sort of, I guess in the trauma world, like a true salvage procedure, like last sort of salvage option you would have perhaps before an amputation or something. So sometimes now it's getting done. Sometimes for an elderly patient with a bad ankle fracture, who may be neuropathic, who may be at risk for complications. So we're starting to get a little bit more literature on it. So I think there's a few good questions, in terms of best practice. And I think those are, to prepare the joints or not, perfusion. We've heard a little bit about that, so I want to get the panelists' take on that. I guess that's the same question. Or how do you prepare the joints? I guess my questions. How long do you go with the nail? Should you do a long nail if you're doing a fusion for, a trauma case or a fracture case, as opposed to an elective TTC fusion? So, the question is, let's just ask question: prepare the joint or not in the setting of an ankle fracture that you're treating, Jim?
I do, yeah, I prepared to, as a foot and ankle surgeon, we're fusing things all the time, so it's not a process that takes me an incredibly long amount of time. I think,
Is there good evidence to support that? Or is that mainly based on kind of just customary practice?
yeah, I mean, I think that the ones that my trauma partners send to me are the ones that they put in that didn't heal, right? So
Problems?
the windshield wipering of that nail in the bone really can be a problem if it obviously doesn't heal. So I think the issue with, and I think you came to Temple and gave us a grand rounds, and the first time I ever saw a TTC fusion for a fracture. Am I thinking of the right?
It was years ago, yeah.
Pretty sure it was
Years
years ago.
10 years ago.
First time I ever saw it, I was a resident. I thought, wow, that's a great solution for a really complicated problem. But the patient selection for this, like who can get, so nobody knew anything about this 77-year-old, and we said we could get her in to the operating room and prepare her joints. But this lady walks like 2 miles a day. She drives. She walks her dog. I mean, she actually is a relatively active lady, and so I think that knowing the patient is really important. You can't do the TTC fusion just because a patient is older. And so for me, I have not figured out the right patient, because somebody who you think is a slam dunk that's going to get a TTC fusion without preparing the joints is someone that I have seen a couple of times come back 9 months later, and you just start seeing that nail windshield wipering in the talus, and you lose a ton of bone. And
Dr. Mehta, what do you think?
I
You
think,
said you
I
don't,
think
you don't do them. What's
I don't
argument?
prepare the joint, but I think the key here is what he just said, which is understanding the patient, right? I look at this as the nuclear option, right? Like you do this, there's no alternative. There's no going back and redoing the ankle. Like you've blasted through everything. And so I want to make sure that people don't leave here thinking, hey, bad ankle fracture in an old person or bad ankle fracture in a diabetic, just shove a nail in them and walk away. I'm still not. This is not the gold standard, and I think we just have to be thoughtful about that. And if you have a patient who is like the woman we're talking about, who is walking 2 miles a day, that to me is a different patient than say somebody who's end stage renal dialysis, who is on a walker, who gets up from their couch and goes to their kitchen and kitchen to bedroom, and that's their entire world, right? So I think these are important things to consider. I also look at this as, if I'm doing this because of a soft tissue envelope. I'm doing this because I want to minimize my surgical time. I'm doing this because I want to minimize my surgical insult. And so things like preparing the joint, they can be done minimally invasively. They can be done effectively, maybe not by myself, but other people who do this sort of stuff. And so I want to do the least amount of surgery that I can to give the patient the functional outcome that they need, depending on who they are. So maybe for this woman, a formal fusion makes a lot of sense. But the types of patients that I'm doing this on, they're not as active as this woman is. And so for me, I have very little enthusiasm for preparing the joint, because I don't think it's going to add value to their overall functional level of care.
Yeah, I think this is a good research question, to be honest, because I think we're starting to do them more. It's become a little bit, more of them. I don't want to say mainstream, or maybe mainstream for certain patients, but you're starting to see it used more frequently. And I think you are starting to get, some patients, referred. Trainees are starting to hear two different things. It's a little
I
bit of
think also
literature.
you exposed a patient to increased risk for a potential non-union at their arthrodesis site. So it's not a benign procedure to do that. One, I'm staunchly in the non-fuse camp, and one, it's because of the increased surgical exposure. I don't know how to do it minimally invasively with the burr. A lot of times these patients are traumatic patients in my practice. But also, a non-union at that site is another complication. There's like a 16% risk of non-union within the literature for fusing the tibio-talar joint. So I think that you expose patients to that risk, and then you also burn the salvage of if that patient doesn't want to walk with a crow walker for the rest of their life, you can just remove the nail, and now you can't do that. So I think for those reasons, I do not prepare the joint.
How big's the nail that you're putting through the joint?
Usually 10 diameter, which is
What's the opening
10
reamer diameter?
Yeah.
What's the opening reamer diameter that you have to get into to get the flare of the nail where the screws go in?
13.
I guess my point is, well, it's not a great joint, right? It's not after you've put a gigantic hole in the joint. Sure, you can take it out and let this person limp around, but we can't claim that that's a better solution, right? So let's just say that this patient went on to a non-union with this nail and plate combo. I'm not so sure that I would care, right? I mean, I was a symptomatic non-union for sure, but we healed there with steel, learning from you trauma guys as to how you heal those distal femur fractures and let them walk on it right away. I don't know. I I agree with you. The open exposure is something that you would worry about, but we've been scope fusing ankles for 30 years at this point, and then now they've got these minimally invasive burrs that you can get trained on relatively quickly. That takes an extra couple of minutes. Now, that's not the greatest. That's not how I do it, but that's the way some people are doing it these days. I'm not advocating that all patients, just like Samir said, and it's a great point. You have to make sure that you're indicating the patient for this procedure who's the right patient. And have I never put a nail in that I didn't prepare the joint? No, I had a 98-year-old female with a really bad fracture dislocation, and she had like venous stasis skin. She had chronic kidney issues, and I did a TTC nail without preparing the joints, and just wanted to get that lady off the table. So I'm an advocate for when you have a situation like this, and I would say most situations, I think it does benefit you in the long run. Obviously, we're talking about opinion here, so. Anyway.
So I want to bring up a couple of just points, the literature, and then I also do want to sort of we started a little bit late. I definitely don't want to run over. I might actually try to stop a little early to get back on time. Certainly not going to try to get through all the cases, but there's a few points in some of the other cases I do want to sort of get across. The literature is a little bit mixed on this. Small case series, right? I mean, this is, case series without joint preparation. This is a review of the literature for elderly patients. That again, not tons of patients in these studies, but this is relatively recent data. And the complication rate is it's not benign in this particular review. It's also, I would say, extraordinarily high either. And this particular case control shows, again, relatively small number of patients, relatively large number of complications. And again, they're earlier weight bearing them in the hindfoot nail group. A lot of complications, right? In this particular study, this is again without joint preparation versus ORAF. Let me I just do want to show a couple of case points without going through the whole cases.
Hey, to your point about length, I think it's
Yes,
really important.
length of the nail. Yes.
These nails, these ankle fusion nails end in the worst place possible. And while they may not all break, I have seen, and I sent you a case like this, where you'll see implant fracture at the tip of the nail. And so I think you have to think about, do you put a nail in that runs all the way from calcaneus up to tibial tuberosity? And unfortunately, there's not a lot of nails out there that do that are hindfoot fusion
But
nails.
at least up to past the isthmus is probably helpful.
Yeah, just something really long, as opposed to ending right where they're going to break their tibia.
Yeah. Do you guys agree with that? If you're going to do a nail for a fracture case, to do something that's not the sort of typical short length, but maybe something that goes higher past the isthmus, for example?
Yeah, my rule is one shorter than the longest nail they sell, just in case you got to revise them so often, you have to put a longer nail in.
Yeah.
I agree with you. The exact same thing with a goal of an isthmal fit
Good points.
for added stability.
All right, so here's an 83-year-old patient, motor vehicle crash. Here's an example of, not quite as dramatic of an injury in terms of the initial displacement, but certainly can see trimalleolar involvement here. So trimal fracture, not as dramatic in terms of initial displacement. Patient uses a walker at baseline. Is this just show of hands on the panel? Is this something you would fix with ORAF? Hands, anybody? Yes, most of you? Okay. All right, so probably something you would consider fixing. Patient, is not, Charcot. It doesn't look to have obvious neuropathy. Does ambulate at baseline. So it looks like this case was fixed.
Just point out that an 83-year-old smoker has a back year history in the just under 100 years, perhaps, if you're being realistic about it. So significant.
Also a survivor. If they made it this far, there's not much you're going to do to hurt
I
them.
was just going to say, Samir, I mean, if they're 83 smoking, it's probably because they have the genes that can support that.
That's supported for their central, but as far away from the heart as this is, the blood supply down here is miserable.
Good point. Right. So, this was treated with, again, fairly rigid ORAF, fairly transverse fibular fracture, tension type fracture, if you will. So here we have intramedullary fixation. So just a thought, again, I think plating the fibula is not always benign. We're making big incisions over this very subcutaneous bone, do a lot of stripping, and then you put a plate that's right under the skin. In certain cases, I think this is a fracture pattern. I would agree with intramedullary fixation for some type of transverse or tension type pattern. Is not a bad idea. When you do the single screw, one thing is it does tend to sometimes varus the fibula. For what it's worth, not a huge problem, but just, it's going to try and straighten itself out. So that's one thing I've always noticed if I do that for pilon fractures.
It's not a huge problem because you rigidly fix the rest of the bone, right? I think intramedullary fixation has gotten very popular, and I have no problem with it. But I think if you're going to intramedullary fixate the fibula, then you need to rigidly fix everything around it. What I see sometimes is people trying to perk everything, and the fixation's all flexible, and that I don't think is a great idea. So I think this is unfortunately great, but obviously not great. But I wouldn't have, what I'm looking at when you go back and look at your not failed X-ray or failing X-ray, it looks really good, and it looks nice and rigid, even with that fibular fixation.
Yeah, and I think if you're fixing a pilon, it's a great option to avoid having to do another exposure. So again, maybe a little bit more fixation than you would consider for a trimal in a younger, healthier patient. So I think it's just, an example of two things. One, considering intramedullary fixation on the fibular side when possible, but still getting rigid fixation nonetheless, especially on the tibia side, as you see here.
Saqib, no, you're showing. Okay, so that was the end of that one.
Yep.
Back to just for a second, two
Yep.
small points. That percutaneous screw that will get into the perineal tendons quite often. It's
Yep.
something that can really be a problem, and
Yep.
it could be a subtle problem. It's in the long out films. Sorry.
And if you put up one of those titanium elastic nails and they back out, they can really be symptomatic there.
Yeah, I mean, she's a little sublux forward as well, but the healed films that you showed. One more. I mean, it's
Not a Beth lateral.
yeah, maybe just a touch of Eris, but if she's healed, she's healed.
Yeah.
It's a lateral Rothman.
Before we finish, there's one other.
I'm just glad you showed that because Jim made the comment about traumatologists not going prone. I go prone for, I would say, certainly the majority of posterior malleolar involvement, like 80% out.
I think there was an OTA AOFAS combined specialty day, I don't know, about 8 years ago. And really one of the only things that we agreed on, Liz Frank fusion versus that one of the only things we agreed on was that traumatologists were really starting to go after that posterior mallet, just like we were very aggressively. So I don't think there's much of a disagreement there. I will say when we talk about, we should just fuse it. We should just fuse it. Trying to fuse these things is a pain in the butt, right? You're trying, instead of trying to put together, a 1,000-piece puzzle, you're trying to build a Jenga tower in the middle of a rocking sea, right? Like there's no stability there at all. You've got to get your length, your rotation. your alignment. I mean, you're not opting for an easier option.
Your point is that fusion is not just some simple thing. Instead of the difficult, put it all back together. Fusion is to put it back together at least some, and then also fuse it.
Yeah, get it in the right spot. I mean, you think about these gunshot wound femur fractures that as a temple resident, we were doing all the time in the subtroch area. You had all these tricks to get the length, the rotation, the alignment right. And then even still, you would still have some mistakes. This is the same type of thing. You've got a dusted pilon or you've got a talus that's just melted and you're trying to get this limb back out to length and the rotation right. Just fusing it is never really that just as easy. It's just as hard in my opinion.
Great points. All right, final words, because we're wrapping up. There's a term for this. Fibula, pro-tibia, or there's different things. I've seen it said both ways in the literature. So you may hear that term when you sort of do, not just really syndesmotic fuse, but you just keep going up.
Saqib, where is the best bone in the distal fibula?
Probably not so distal.
In the tibia.
Or proximal, yeah. So this is again a technique that's been around for a while. Not a great data in the literature to guide it, but again, it's just kind of like Gene said, getting additional fixation by keep going. Locked fibular nails is something we really didn't see in any of the case examples. This has been out now for a little while. There are some commercially available ones. This is a paper I think we just reviewed in Journal Club not too long ago. Dr. Samir says he does this almost all the time now. I'm just talking about ankle fractures in general, not in the elderly. So plating sometimes on the medial side, even for tension type medial malleolus fractures is something I don't do a ton of because I don't like putting plates there if I don't have to. But I think you've seen a couple of examples like that. So just this, you see this term robust fixation. I don't know where this came up, but it basically means you're just doing all, like here's examples, right? Plates on the medial side, multiple screws going across the ankle. So I'm going to sort of just go to my wrap up slide. We got a lot of cases just in case. Sorry, everybody, I appreciate you all sending me the cases. I'm sorry I couldn't get to all of them, but just to wrap up, elderly ankle fractures, we're concerned about wound healing, right? We're concerned about fixation. We're concerned about the need for early mobilization, or in fact, the patient's going to do it anyway. You need more fixation than usual. Plating fibulas is not benign. Wound complications happen. Your options include standard ORAF with additional techniques, intramedullary fixation of the fibula, locked or unlocked. This fib, pro-tib, plating where you put in, screws all the way across, or even hindfoot nailing. We talk a lot about that. So hopefully more data is coming out. Good guidelines are still lacking, but I think you saw some interesting case examples. And, it's interesting. We started off the discussion, Dr. Mehta, talking about casting. I mean, I think we talked a lot about surgical techniques in this course. And Jim pointed out how, casting is not a benign thing either, but that's always an option too. So, all right, I want to thank our panelists. I want to keep moving. So thanks, guys.